Again, thank you so much, Dr. Gregory. And now we will move to a very important presentation, which is very excited for us as pediatricians as well as adult pulmonologists, where we end with a major decision for lung transplant. So the next speaker is Paul Aurora. Paul Aurora, he's from UK. He is a consultant pediatric respiratory medicine, and also he's lung transplantation physician from Great Ormond Street for Hospital for Children. He's very known to our community. We are very happy to have him in today, and also we had the opportunity to see him and to have him in our previous meetings. And it's a great pleasure, Dr. Paul, to have you again. So the talk is about lung transplantation in CF from guideline to clinical practice. Dr. Paul, the mic is yours.
Thank you. I hope you can hear me. Please,
we do. Yeah.
Good. Well, it's a great honor to be here, and thank you for the invitation to speak at this meeting again. On this occasion, I don't come to you. Instead, I welcome you all to my home in London. A couple of you have visited in person before, so welcome back. And as for the rest of you, I hope one day you can visit me in person and we share a meal or something. But at the moment you visit virtually, I will show you it is 7:30 a.m. in London. It's dawn. You see the sun is just coming up behind me. I'm pleased about that. It's the most beautiful time of the day. But the other advantage is that in London this week, we've had, in my area, had some trouble with internet traffic, with so many people working at home. And I'm hoping at this time on a Saturday morning or weekend, it will be fine, because the only other people using the internet are small boys playing computer games whilst their parents are still sleeping. But if we do have a problem and I suddenly disappear, please give me a couple of minutes and I'll find a way to reconnect. Hopefully there won't be an issue there. So what I'm going to speak to you about today is lung transplantation in CF. I'm going to make an assumption that many of you know very little about this topic. So I'm going to cover the basics as well. I'll be covering the basics of transplantation, survival figures, what rationale do we use for listing patients when we do, and then a very small amount about post-transplant care. But unfortunately, we don't have time to cover absolutely everything. So the history of lung transplantation is that we've been doing this since the early 1980s. The numbers have steadily increased, and according to the International Registry, we're doing more than 4,000 lung or heart-lung transplantations every year worldwide. Probably the numbers are slightly more than that, because there are a few centres that don't submit to the International Registry. And of that huge number, only a tiny proportion are performed in children, just 90 to 100 every year. And there are numerous indications, but in summary, these are all different forms of end-stage lung disease. The terminology I need to explain to you. Initially, when we started doing transplantation, it was heart-lung transplantation. So we would transplant both lungs and the heart and the connecting vessels as a single block with the recipient on cardiopulmonary bypass. Now, surgically, that is a slightly easier procedure to do. If you're just doing the transplantation for someone with, for example, CF, then you're removing a healthy heart. But what we do in that case was domino that heart. In other words, the heart that we explant from the CF patient will be used to be transplanted in someone who is awaiting a heart transplant. Now that procedure isn't performed very frequently anymore because it's not considered to be necessary. Instead, we perform double or bilateral sequential lung transplantation, which is just transplanting the lungs and leaving the heart in situ. And that can be done either on cardiopulmonary bypass or off bypass. We also have the option of single lung transplantation, which is just to make better use of donors. So we can then give a single lung transplant to 2 recipients from a single donor. However, that's only a suitable operation in recipients who have something like COPD or emphysema. It will not work for someone with suppurative lung disease like cystic fibrosis. So it's not done for CF. Here's an indication of how many numbers are done. These data are coming from the International Society for Heart and Lung Transplantation Registry. And I should make a note that here that there may be a few centres who don't submit to the registry, so it's possible the numbers are slightly higher than this. But you can see of the 4,000 transplants that are done every year, virtually all of them are either done in North America or in Europe, very few outside. And the type of transplantation you can see is largely bilateral lung transplantation. Only a small number of single lung transplants are done now. This slide shows the proportions rather than the absolute numbers divided by the age group of the recipient. And I want to highlight a few things to you here. I hope you can see my arrow. In the green here, this is the proportion of children under the age of 10 who receive transplants every year. And you can see, since we started recording the data in 1988 to the most recent data in 2018, that proportion has become tiny. The actual numbers have stayed relatively similar, but the number of transplantations for older recipients has increased greatly. So that's why the proportion has gone down. And then for adolescents in the light blue, just below, you see, again, also the numbers are very, very small in the more recent years. The majority of transplantations are performed in adults. And then the last two things I will highlight to you on this is red. This is recipients over the age of 66 years, which you may think is quite unusual, but it is happening more and more. And the median age of the recipients has steadily increased. So it's now gone up to 60 years. In terms of the primary diagnosis, well, these are the total numbers divided by the primary diagnosis for adult lung transplantation. And you can see in adult transplantation, the blue here is CF. Approximately 20% of transplantations are performed in subjects with CF. And that proportion hasn't really changed over time. And in pediatrics, where the numbers are much lower, remember, it is more like 50%. And there is much more variation year to year because the total numbers are smaller, but we're still at approximately 50%. Next section, I'm going to talk about survival. This plot is a Kaplan-Meier plot. So this is the number of patients still alive plotted against time. You can see that the median survival, when we first started doing transplantation in blue, was around 5 years. But now in the more recent era, we're up to a median survival of 7 to 8 years. And these are data from adult subjects, where there are many more subjects we can look at. But I'm going to show you a little more detail on that. So this is a comparison of adults and children. And the adults here are in green, the children are in blue. And if you can see that the median survival is similar, although slightly better than adults, 6 to 12 months better for adults. But then as you go further out, the curves cross over, and so more children are alive at 10, 15, and 20 years compared with adults. However, the reason for that is the plot I showed you earlier, which is that the average age of adult recipients is now 60 years. So if you go 10, 15, 20 years out from transplantation, many of these adults are dying from other causes unrelated to their graft survival. By diagnosis, and this is in adults, the cystic fibrosis recipients are plotted here in purple, and you can see that their survival figures are significantly better than other subjects. The median survival in adult subjects with cystic fibrosis is actually 10 years. And this is, we think, largely because this is a younger cohort. These are young adults, whereas for most of the other diagnoses, it's older adults who are being transplanted. The graph is different for children, though. Here, I'm afraid I've plotted the CF group in green, but you can see that actually they're not doing better than other pediatric groups, and if anything, doing slightly worse than our other biggest groups, which is children with idiopathic pulmonary arterial hypertension or interstitial lung disease or obliterative bronchiolitis, including the post-BMT ones. And then if you compare the cystic fibrosis recipients by age group Ignore the green here for the moment because this is single lung transplantation, historical. We don't really do that anymore. But look here at the purple and the blue. This is a very important message to you, which is that the survival figures for adults with CF receiving lung transplantation, they have a median survival of 10 years, whereas children with CF have a median survival of only 5.5 years, according to the International Registry. Now, there are a number of reasons for this, in my opinion. I don't have any kind of analysis to prove my hypotheses here, but I will give you my hypotheses. The first being that we're so much better at treating CF now that for a child with CF to need a lung transplant, something has gone wrong somewhere. It may be that the family weren't giving medication effectively. In other words, the child wasn't adhering to the treatment that was prescribed. It may be that the child had an unusual infection, for example, with a non-tuberculous mycobacterium. It may be the child had another problem, for example, was born with meconium ileus and had a large gut resection. These are all things we see in referrals to our centre, but as you can imagine, all of those conditions will also impact upon post-transplant survival. That's the first thing. The second thing is that many of our CF transplant recipients are adolescents, and as you know very well, that is a very challenging time for a lot of reasons to keep a child well. And then the third reason is that this is a little bit more controversial, but we do have some data for this, is that most pediatric lung transplantation is performed in small volume centres, and we know that small volume centres have poorer outcomes than large volume centres. And just to be a bit more optimistic about those data I showed you, I'm going to show you the survival figures from Great Ormond Street Hospital in London, which is where I work. This is our own centre, and as you can see from the most recent era, I cannot even give you a median survival because even 10 years out, we have a survival of more than 60%. Why is survival so poor? The main cause for that is that transplanting lungs is difficult. It's not just surgically difficult, but it's also difficult to manage for the medical transplant team post-transplantation. The lungs are exposed to the environment, and as a result of that, have a huge amount of antigen-presenting cells. And then as a result of that, lungs reject very easily, much more easily than kidneys, hearts, or livers, and almost as easily as the bowel. Acute rejection is much more frequent in lung transplant recipients, and as a result of that, we have to use a higher protocol for maintenance immunosuppression post-transplantation, and as a result of that, we get more complications of post-transplant immunosuppression, such as overwhelming infection or malignancy. And you can see that these causes together add up in limiting our survival. Early on, post-transplantation in adults, these data are, infection is the commonest cause. And as you go further out, this red line represents a condition we call obliterative bronchiolitis or bronchiolitis obliterans syndrome, which is the clinical correlate. And that is a form of chronic lung rejection. And this is along with infection, this is the major reason why our survival figures are relatively poor compared with other solid organ transplantations. So with such poor survival figures, what should be our rationale? And here we're quite strict about it. We would only offer lung transplantation to a patient if our assessment is that their life expectancy on full medical treatment, but without a transplant, is 2 years or less, the best we can judge. In addition, there should be no absolute contraindications. That's a complex issue, which I can't go through in full detail, but the contraindications will vary to a large degree from centre to centre, and also by time. So issues that we considered to be contraindications now, we wouldn't have considered in previous years. But there aren't that many absolute contraindications to transplantation, and if necessary, we can cover that in the discussion at the end. In addition, we have to judge that the child has a poor quality of life, and that has to be by their perspective, not just the perspective, our own perspective. And it is crucial that we give full informed consent, including the family knowing what the limited survival figures are, and also the onerous burden post-transplantation of medical care, which I will cover shortly. So what are our great challenges ongoing? Well, the question used to arise frequently is whether we should do this procedure at all, with the survival figures being what they are, and I will answer that. How can we improve outcomes? How can we increase the number of donors? And how can we decide who gets a transplant? I don't have a lot of time to cover how we can improve outcomes, but I will touch on the other three issues. And I'm going to start with the first one. And the question being, if the survival figures post-transplantation are so poor, how can we be sure that transplantation extends life? Normally, if we're trialing an intervention, we'd organise a randomised controlled trial. Of course, that was never really possible for transplantation, and is certainly not possible now. So that's out. We can compare our post-transplant survival to other populations, and an obvious one would be to compare to the general CF population. But when you plot those two groups, you can see their survival figures are very different. And you immediately realize that you have selection bias here, because the patients who are being transplanted are not being randomly selected from our CF population. They are the sickest patients that we have, who we are putting forward for transplantation. So this isn't a valid comparison. Could we perhaps compare the survival figures for the transplanted patients with the patients who we list for transplantation, but who die before getting organs? Superficially, that may sound like a good idea. And when we compare those two groups, we can see that the transplanted patients have a better survival. But again, with this too, survival bias is applying, because the patients who are dying on the list are often the very sickest patients who simply cannot survive long enough to get a donor offer, because it's not like we can choose when an organ becomes available. So the transplanted patients may have been slightly healthier to begin with. So this isn't a valid approach. And instead, we have to use a more complex technique. We use a technique called Cox proportional hazards modeling, which was developed by a very famous statistician called Sir David Cox, working, I think, in Cambridge. And he actually developed it specifically to answer this question for heart transplantation, but it's easy enough to apply to lung transplantation. It's a form of multiple regression where the dependent variable is survival. And I'll just show you how we do that. So this is a plot of risk of death, or cumulative hazard, plotted against time. That's an easy enough thing to plot, but as well as plotting it, we can also develop an equation that expresses it mathematically, where the variables in that equation are predictors of prognosis for that condition. And in this case, we're talking about CF. So in other words, we can develop an equation based on our registry data or local database, where we use various clinical and physiological measurements to predict how long people are going to live. And because we're using a historical database where we know how long those patients survived, we can be fairly sure that will be accurate. And then from the time of transplant, there is a different situation. There is post-transplant survival, which we can also measure. And using a similar method, we can compare the two curves, and if they go in this direction, in other words, a reduced cumulative hazard post-transplantation, then we know that transplantation has reduced the risk of death, and we can even quantify that reduction in risk of death. It's not as complicated as it sounds, and there have been a lot of studies reported now. And in fact, the first part of that, in other words, which physiological and clinical measures predict survival in CF, that is a very well-developed field, and it was one of the first areas I researched actually as a fellow. I did quite a lot of work on this. And we've identified lots of measurements that we can take in the clinic that will tell us and the transplant centre how long a patient is likely to live for. And I won't go through all of them, but I've just headed them here in domains, and they're ones you will make complete sense to you as CF physicians. So spirometry measurements, exercise tolerance, blood gases, nutritional status, the rate at which the patient is declining, female sex, girls definitely do worse than boys, energy expenditure, which sometimes gets forgotten, but the easiest way to record that is the resting heart rate. A patient who is tachycardic, has a high metabolic rate, and multi-system involvement, such as liver disease and diabetes. And using all these parameters, we can develop prognostic models. Now, I wanted to highlight to you one very important study that was published more than 10 years ago now, but caused quite a drama at the time and indirectly led to a change in practice. It was published by a friend of mine, Ted Yu, working from Salt Lake City with some mathematician colleagues, where he went through the United States database and reviewed a 10-year database of children who had been transplanted there, most for CF, but for other indications too. So more than these were just children with cystic fibrosis, take that back. So 514 children listed for transplantation. And during that time, in the United States, patients were being listed by waitlist seniority. So in other words, the child who had been waiting the longest would get the donor offer. And during this study period, approximately half the patients were transplanted, about a third died on the list, and the remainder were still waiting at the end of the study. And they used the technique I've just described to you to estimate the survival benefit of transplantation. But the results were not what they expected and caused a little bit of a drama. These are the patient characteristics, which I'm not going to go through with you in detail, but I just want to highlight one thing. One of the things that the team calculated was, at the time the patient was put on, was transplanted, what was their, so at the time they were put on the waiting list, what was their 5-year predicted survival? And as you can see, these patients at the time of listing for transplantation, the majority of them had a predicted survival of greater than 5 years. The next part of the analysis was to work out the survival benefit for transplantation. And this is all of the children in the study who received transplants. The ones in gold here had their lives extended by the procedure, according to this model calculations. The ones in blue were in an uncertain zone, were within the limits of confidence of the analysis. And the ones in red were calculated to have their lives shortened by the procedure. And that was the majority of children had their lives shortened by the procedure during that 10-year period. That is, as I said, is not a result that was expected, and it caused a lot of upset. But I will point out to you the reason that happened. You will remember when I told you what our criteria should be for putting someone on a list, which we've always followed in Europe, is a predicted life expectancy without transplant of 2 years or less. What had been happening in the United States is that patients were being listed a lot earlier, and the centers realized that the reason that was happening is because they had a donor allocation system that relied upon waitlist seniority. So if they waited for a child to be in the last 2 years of life before putting them on the list, there was a chance they wouldn't get donors. So they were listing patients earlier and earlier, and with many centers in competition, there was an imperative to do that. So it was already realized before that even happened that this was a risk, and it had already been realized that other centers were doing better. So a whole series of survival centers had been published already from Europe, including our one in children in 1999, showing that there was a clear survival benefit. So in this case, the United States was an outlier. And the understanding of that caused them to revise their donor allocation policy. So instead of waitlist seniority, they looked at 2 other options. Maybe highest post-transplant survival would be one option, but then better than that, the greatest survival benefit, which seems logical. If we have the ability to do this modeling in a research approach, why not use it as a clinical approach as well, and use the same model to decide who gets a donor offer. And that is pretty much what happens now. A very similar system to what I've described to you for research is now used to allocate organs in the United States and more informally elsewhere in Europe. In the United States, it's called the lung allocation score. It was introduced in 2005. And without going through all the details, it is patients 12 years of age and older are prioritized. And when donors become available, to a large extent, the donor is directed towards the person who will likely get the best survival benefit. And the covariates in these models are things that you will expect to see. One advantage, this is applied to all diagnoses, not just to cystic fibrosis, but one advantage is it has directed more organs in the United States towards recipients with cystic fibrosis rather than other groups, because they tend to do better. While I'm on this topic, I should mention this. This is very important to your own patient cohort if you're working in the Gulf countries. Allocation of organs for overseas residents has become a big issue. Now, in the United Kingdom, we have a rule that UK and European Union residents get priority when donors become available, and we can only pass on donor organs to non-residents if there is no resident waiting for that same organ. Now, if the potential recipient is a large size adult, then that's still okay. They still have a decent chance of getting organs. But I'm afraid if it's a small adult or a child, and most of our adults with CF are small, then your chance of getting organs in that system is close to zero. So in practice, we are not able to do lung transplantation for Gulf residents. And that's a question many of you have asked me. That's not something that's going to change. And my last time I reviewed this was just a few weeks ago, actually, for a patient. It's now the case that the other big pediatric centers in Europe are in the same position as we are. So Hanover in Germany and Barcelona in Spain are not able to offer transplantation in practice to Gulf residents either. So if you do need to send a patient outside of the Gulf, you'll need to go to Canada or the United States. So I can, of course, advise you about which center to go to. But of course, you do have transplant centers in the Gulf as well, including one very large one here. When I noticed when this center opened, it made me feel old, actually, because I started working in transplantation even before 1998. But still, 22 years is a long time, and it's a large volume center, so you have that option. Very briefly, how do we increase the number of organs? Well, there have been two advances in the last decade which have helped us to some extent. One is DCD donation, which refers to donation after circulatory death rather than brainstem death. It's a slightly different process, but it is allowing us to access more organs. And then this system, which to some degree is linked with it, but can also be used elsewhere, this is ex vivo lung perfusion. So rather than discarding lung offers where we think the donor lungs are borderline, we're now able to put them on a rig outside of the body, ventilate them and perfuse them. The perfusion circuit is kind of like a reverse ECMO machine in that it deoxygenates the blood that's coming out of the pulmonary artery, and keep them in that state for many, many hours, and hopefully improve the condition of those donor lungs to a degree where they can then be used for transplantation. So that's an exciting area to be working in. Briefly, I will tell you about the basics of post-transplant care. All of patients who receive lung transplantation need long-term immunosuppression and we use 3 agents, tacrolimus, either MMF or azathioprine, and corticosteroids. They often need prophylactic antibiotics, antivirals, and antifungals, and all non-respiratory CF care needs to continue. This next bit is crucial. You can have the best surgeon in the world and the best ICU in the world, but if you don't have good long-term medical care, then the patient will only survive for 1 or 2 years. It is complicated long-term care. Prompt treatment of rejection and infection are essential, but it's difficult to distinguish between the two. So we need close monitoring of symptoms and home spirometry, prompt investigation and treatment of any decline with a low threshold for bronchoscopy and biopsy, which is this time yesterday, that is exactly what I was doing. A child who had a drop in spirometry of 10%, but no symptoms at all. We still took her to theatre and did a transbronchial biopsy. And that's got to be coordinated by a transplant centre or you won't get good results. And then the last thing, the penultimate thing just before I go, I'm just going to point you in the direction of this further reading published last year in the Journal of Cystic Fibrosis from the CF Foundation, guidelines for when patients should be referred for transplantation. And the key thing is refer early so the family have a chance to talk about it. The specific guidelines for adults is listed here. Hopefully you've got a copy of the slide so you can refer to that, but otherwise go to the guidelines. And for children, slightly different and even earlier. And then the last thing is, I'll just leave this up. Don't hesitate to get in touch with me. My email address is here, and I'm happy to take any questions about transplantation, about CF, or about complex lung diseases, because that's what we do. And if anyone wants to visit here and as an observer, or even come for 2 years as an international fellow, you are very welcome.
Thank you so much, Paul. Thank you so much, Paul. Paul, thank you so much for your presentation and your guidance and your advices. We really appreciate that, and especially the time is very early in your area, and hopefully that The internet went very good and very without an interruption. We don't have any questions, but probably I will ask you one question. What do you think from your anticipated lung transplant data nationally after the availability of the new advances in CF managements, i.e., the CFTR modulators? Do you think these medications or this will reduce the need for lung transplant, or just will delay the process?
Yeah, that's a very important question. Thank you. Already in the last 20 years, we've seen a big change in the number of children being referred for lung transplantation. 20 years ago, it was common. By 10 years ago and 5 years ago, it was already becoming rare because CF care had already improved so much with centralized CF care and networks. And most of the children we were being referred even 5 years ago were children with non-tuberculous mycobacteria, which is a very risky thing to transplant anyway. And I think that trend will increase with the introduction of new biologic therapies. We are expecting only a very small number of children to be referred to us in the future, and instead for lung transplantation in CF will still exist, but it will mostly be an adult exercise rather than a pediatric one.
Thanks, Paul. A very quick question. Is Mycobacterium abscessus or exophyla a contraindication?
So this will vary from center to center. I will just run you through our own policy. We used to transplant patients with Mycobacterium abscessus because we had, early on, we had 2 or 3 good results. Our longer term experience has been much more unpleasant. This infection is almost always recurs post-transplantation, and then it behaves like a malignancy almost. And although we are just about able to keep children alive, you may have seen our case report in Nature about a child who's being kept alive with phage therapy post-transplantation. It is a huge undertaking though, and not necessarily doing the right thing for the child. So we now consider Mycobacterium abscessus to be an absolute contraindication, although other NTM we will still transplant. And I think that's the case for most of the other centers I'm aware of, where abscessus is an absolute contraindication. Exophilia, as far as I can tell, the policy varies from center to center, and in our center currently, we will still transplant those patients.
Thanks very much, Paul. I think that was a fantastic talk, and thanks again for waking up that early in the morning, and look forward to seeing you again next year, please God.
You're welcome. The pleasure was mine.
Thank you.
Thank you so much. Appreciate it, Paul. Thank you.